Hey, how you doing? This is Ken Kinter. I'm an assistant professor at Rutgers University, and welcome to Diagnosis and the DSM, what they are, what they aren't, and what they can be. This is sort of a reboot of the original DSM-5 video that was done, actually the most popular video I've ever done, which speaks to how complicated that book is and people's desire and need to understand it. You got my email here, and you also have our site at the bottom, sites.rutgers.edu, where we have additional videos on mental illness, trauma, psychiatric hospitals, addiction, things like that. So we thank you for viewing. Feel free to like, feel free to comment, feel free to share. We'd love for you to subscribe. And also, if you have any suggestions for other content you would like us to cover, feel free to add that into the comments or reach out to me via email. Just a heads up, this is a longer video. This is about 40 minutes, so I would love it if you could watch it. And if you want to pause it and save it and watch the rest another time, there's a bit that's a go through the DSM, so it's a little dry, but if you got to take it in two passes to catch it, that's a good thing. This presentation and all the others like it is sponsored by the New Jersey Department of Health and the New Jersey Department of Human Services, as well as the Rutgers Institute for Inpatient Psychiatric Rehabilitation. We are grateful for the support that makes our work possible. So what we're going to talk about in this video is we're going to talk about diagnosis, the multiple purposes of diagnosis. And we're going to take a walk through the DSM, as I mentioned, through the different categories, which hopefully will serve as a bit of a thorough introduction to it for many of you or a review. We're going to talk about person-first language, what that is and what that means and how that interfaces with diagnosis. We're going to talk about diagnosis as a process as opposed to a one-shot deal. And we're going to talk about trauma, which is one of the hidden drivers of a lot of what we see in the other elements of the DSM, and PTSD. And we'll talk about the the continuum of trauma as opposed to it being kind of an on-off switch. So we'll get more into that as we go. So the idea of diagnosis is the identification of the nature of an illness by examination of its symptoms. Okay, so that makes sense. You look at the symptoms, you figure them out, you figure out, okay, what's the syndrome that is being caused, what's causing these symptoms. But there's also a limitation in there because symptoms can be many different things. So how do you differentiate one thing from the next? The other thing is in mental illness, we don't have tests. There's no Mr. Jones, you tested positive for bipolar disorder. We don't have an X-ray or a blood sugar or something like that. So our process is a little more complicated and maybe a little less scientific, a little harder to do. Now, diagnosis also serves several masters, and that also makes this difficult. So the primary role of diagnosis, I hope, is to indicate the right treatment. You get the diagnosis right, that points in the direction for the proper treatment so that the person can get help. However, diagnosis is also essential for reimbursement. It's how you get paid. And most of the time, those two things walk together, but they can clash. And we'll talk more about that as we go. And then an underutilized aspect of diagnosis is as an educational tool, using diagnosis to teach. And I don't think we do nearly enough of this. And by involving someone in the diagnostic process from the very beginning, you start that educational process from the very beginning. The idea that very many people don't know what their diagnosis is or they don't know what it means is not helpful to anyone. So here is the book, the latest version of it, the DSM-5-TR. And again, as we mentioned, this is the book that has all of the illnesses and all of the symptoms in it. And again, we don't have an objective test. So you can kind of see in this process the strengths and the weaknesses of it, which we'll go into a little greater detail. So, for example, there are many challenges to getting diagnosis right. I don't pretend to be a complete expert at it, and I've been doing this for about 35 years. So many challenges, among them including time. You may be under a time crunch to come up with a diagnosis for someone at first visit, long before you have a real comprehensive picture of what's going on with that person. The biggest indicator of what symptoms someone has is their own report. Their own report may be inaccurate, it may be biased, it may be involuntary. And again, symptoms can be many different things. Like a fever can be many different things. You need other things to be able to figure out what's going on with that person specifically. Pros and cons of collateral information, which can also be biased, which can also be inaccurate. Information can be incomplete. It takes a while to get the whole picture. The DSM itself, as indicated, there have been several different versions of that book, so it changes over time. Some people's diagnoses have ended, and then they end up getting a new one as the book changes. So the old saying, once you know the rules, they change them. With mental health diagnosis, there's also the element of stigma. Just having a mental health diagnosis carries significant stigma with it. And then certain diagnoses, as we'll talk about, have additional stigma in them. The idea of somebody being diagnosed, particularly with mental illness, is very fear inducing. So a person may change their story consciously or unconsciously to avoid being diagnosed or avoid getting certain diagnoses. A client's presentation can change over time. Someone can present as depressed once and manic the next time, or they can present under the influence one time and not in the next. So part of diagnosis is seeing how somebody does over time, which is at odds with we need a diagnosis from the gate. Insurance plays a role in this because insurance will pay for some diagnoses and not for others. So they will pay more for some diagnoses and not for others. There was a famous case here in New Jersey about a psychiatric hospital that gave everybody the diagnosis of bipolar disorder because that was the highest reimbursement rate. Medication issues. There has been a lot of pushback that a lot of this book is about medicating people. So you make the diagnosis so that you can prescribe medication. And medication is one of the treatment modalities, but it's not the only one. And it should not be based completely on that, nor should psychiatry be completely based on medication. And then there are other issues as well. I'm sure there are some that I missed on this list that you've come up against. So among the criticisms of this diagnostic process is diagnosis is not prognosis. Even a diagnosis like schizophrenia, which is considered one of the more severe diagnoses, it doesn't tell you how it's going to come out. There are people with schizophrenia that are working full time, married, successful. And there are other people that have other diagnoses that may seem less severe, but the person is more disabled by them. So that's part of the stigma is that the diagnosis not only says what you have, but it implies what your course of treatment is going to be. And the reality is we don't know long term. Even within certain diagnoses, there are stigmas. For example, addiction, there are certain ones. And we'll talk about this SMI, SPMI, which stands for serious mental illness versus severe and persistent mental illness. We'll go into that a little bit later. Certain diagnoses carry more weight than others, say personality disorders and some of the psychotic disorders. The whole idea of diagnosing someone sort of absolves everyone else in the situation from the process. So it says, okay, this person has a diagnosis, this person has a problem. Well, what happens when the problem is sort of systemic within a family or within a group of people? Sometimes the person being brought in for help is the healthiest person in the family, what we call the red flag. They're the one that's healthy enough to indicate that something is wrong. And then the family responds by shutting that down. And this is the situation with the identified patient. Insurance wants one person to be identified as the patient. So if you have a couple that's having marital problems, who's the patient? And you can see how that opens up to all sorts of problems. Diagnosis can be used as punishment. You're the patient, you're the problem, you're the one that needs help. Over and under diagnosis. We hate to overdiagnose people and make them seem like they are more ill than they really are. And then underdiagnosis, you may not get reimbursed. So we may not be doing favors either way there. And again, because we are making the diagnosis based on symptoms, which is based on report for the most part, and what you observe, we don't address the cause. So, what caused that to happen? What caused the depression? What caused the anxiety? What caused this? We don't really address that. And very often that's trauma lurking in the background, which, as we'll talk about at the end of this presentation, doesn't really get covered. Diagnosis is much more about classification than functionality. Those of us who remember the multi-axial assessment, you had the global level of functioning. What number from 1 to 100 is a person functioning at? Aren't we more concerned with how well somebody's doing than what the numbers are of their diagnosis? And I think something's been lost along the way there. Also, the book is one size fits all, so it doesn't really address cultural issues. There may be things that are completely appropriate to a culture that aren't really accounted for and in the diagnosis. And the diagnosis sort of negates that innate difference between people. It does make a reference to, is this outside of the bounds of the normal culture? But I don't know if that's exactly sufficient. Another issue regarding diagnosis is where you work. I started working out in emergency rooms, and there it was about speed. You made a provisional diagnosis and you made it fast and you made it right then. You were really just trying to figure out where that person needed to be next, whether it was inpatient or outpatient. And that was kind of it. As you work with people over time, say in a partial care program, you get to work with them and refine their diagnosis and do more of this educational piece over time. In state psychiatric hospitals, very often people inherit diagnoses from wherever they were before and they don't change right away. So that's a challenge. In academia, we study the diagnoses and the criteria and all that kind of stuff. However, is it applicable in the real world? Is what works in a research study necessarily functional in a treatment setting with real people? And then the last element of diagnosis is working with families, because not only do you have to educate the person about what the diagnosis means and to some degree talk to them and see what level of agreement they have with their diagnosis, but you also do that with the family. It becomes a jumping off point for educating the family who's as involved in the person's mental illness as they are in many cases. All right, so here's the part where we go through the DSM. Stay with me or take a break if you need to. But we have more stuff at the end where we talk about stigma and trauma and all that kind of stuff. So here is a summary of the book, The Mental Disorders as per the DSM-5-TR. The ones that are red and bold-faced are the ones I'm going to be spending more time on because I think they're the ones that we spend more time on in the field. We will go through all of them a bit briefly. Some of these also require more specialties and special knowledge that I don't have. So we're going to go through this because otherwise this thing would take a whole lot longer than it takes. So we're going to start off with neurodevelopmental disorders. Some of these I'm sure you've heard of before. Intellectual disabilities, otherwise known as mental retardation, otherwise known as developmental disabilities. This is done through testing. So it's not really a diagnostic thing per se. You've probably also heard of autism and ADHD. Asperger's was also a diagnosis in this area that got folded into autism. So these are things that develop in childhood and have more of a neurological basis to it. And like many of these diagnostic categories, I would want to have a doctor going to bat with me before I just decided that this was going to be a diagnosis. I would not want to go this alone. Schizophrenia spectrum and other psychotic disorders. This one we spend a lot of time with, especially us on the inpatient side. So what we see mostly is schizophrenia and schizoaffective disorder. And we'll talk about what these symptoms are. Schizophrenia is primarily the presence of a psychosis. And then there is schizoaffective disorder, which has the psychosis, but also has a mood component along with it. Interesting to note that there are doctors that will not diagnose people with schizophrenia anymore, because if you diagnose somebody with schizophrenia, you can't give them antidepressants or mood stabilizers. If you diagnose them with schizoaffective disorder, you can. So in a strange way, the treatment is directing the diagnosis as opposed to, the normal process that we talk about. Because insurance has spoken and said that you can't give somebody antidepressants if they have schizophrenia, even if you feel it's indicated. So you see some other things here. There's a personality disorder in here, which we'll talk about later on. One of the real challenges in this area is when someone has what they call a first break. You get somebody who's 18 to 22 years old, and all of a sudden they start demonstrating psychotic symptoms. Do you go right to a diagnosis of schizophrenia with that person? Now, the book says it's a month, and it says you go through things like brief psychotic disorder or schizophreniform disorder first off. So there's a time factor to it as well as a severity factor. The other interesting part of this is the drug-related part of this, and you'll see a couple categories here. You'll always see a psychotic disorder due to medical condition. You'll see that in all the categories. You'll also see other and unspecified. So if you're in the ballpark, but you don't know exactly for sure, you've got that sort of back out. And I'm fine doing that. Start with a general diagnosis, get it in the ballpark, and then get specific with it later on. So just to back up a little bit, for those of you who aren't familiar, psychotic symptoms are comprised of, these are the major ones, not all of them. So these are the positive symptoms, symptoms that are added by the illness. So you have delusions that are false beliefs. This person may feel that they have special powers or special abilities, or they may feel like people are after them, want to harm them, want to kill them. And these beliefs don't move in the evidence of fact. The person believes them regardless. You also have hallucinations. Hallucinations are stimuli that the person is getting. They are genuinely experiencing this, but no one else can. So visual hallucinations would be someone sees something that no one else can see. They hear things that no one else can hear. The one that we see the most in mental illness is auditory hallucinations, voices, particularly of a disturbing nature. Things that are primarily visual hallucinations or other types of hallucinations can be a sign of a medical problem or a substance issue, and that's really important to differentiate. There's also disorganized speech, disorganized catatonic behavior. A person literally speaks in like a word salad where nothing they say makes any sense. We had a gentleman who used to call our crisis hotline who asked me the question, if I was a Roman centurion, what kind of cigarettes would I smoke? And that was kind of a nice example. He was trying to ask me something, but that's what came out. So, in addition to the positive symptoms, not meaning that they were good, but they are added, there's also negative symptoms, things that the psychotic disorders take away. They take away emotional range, a person being able to start and finish an activity, speech as a whole, or content in speech, and the inability to experience pleasure. It's very dulling and it just sort of stops that person's vibrant experience of life. And then also you have cognitive symptoms where a person just has a really hard time. I call it the sock drawer. You have that drawer in your house that has all of the junk in it in your house, but not enough of anything to do any one thing. And it's your thoughts. They're just all packed up uh, closely together. Problems with memory, and of course, the difficulty in being able to recognize their illness. Anosognosia, a very interesting word to look up. We don't have time to get into it here, but it's worth a deeper dive. One of the other things that gets impacted in the psychotic illnesses is something called executive function. Your brain is the CEO of the company. It makes all the decisions regarding the rest of your body. And so if something bad happens to your foot, your brain makes the decisions about what we should do about the foot. If there's something wrong with the brain, the foot can't reciprocate and take over. So these are the executive functions that the brain monitors: emotions, behavior, problem solving. And when the brain has a problem in it, these things are all affected. And the person basically loses the ability to manage their life, manage themselves. So as you mentioned before, schizoaffective disorder has a mood component, and now we're moving into that direction. So here we have bipolar and related disorders. The big thing about bipolar disorder is the term mood swings, this sort of up and down swing. That used to be called manic depression back in the 70s. Bipolar disorder, now not everyone has the upswing and not everyone has the downswing, but there are sometimes rapid swings in mood. So on one side, you have hypomania or mania, which is what we see here at the bottom. It's sort of being hyper energized. It's these cycles of being hyped up, not needing to sleep, being over energized. And then very often that's sort of followed with a crash. A person can't maintain that. I have a friend that has bipolar disorder, and I check in with how she's doing just by asking how many hours of sleep she's getting a night. If she's over 3, she's okay. If she's under 3, we're probably working on a manic situation. These are the different types of bipolar disorder. Bipolar 1 has that mania. Bipolar 2 can only have hypomania. It doesn't have the full mania, but they do have the depressed swing. And as usual, you have medical, other, and unspecified. So next up is depressive disorders. Depressive disorders, I always relate this to if you've lost someone close to you and you're grieving. It has that feeling to it, but it may not have a clear start point. It's not connected to a death. It's just there. It could be connected to another life event, or it could just operate independently of its own. So, with depression, you can see the symptoms here: feeling sad, loss of interest or pleasure in life, changes in appetite, changes in sleep, feeling worthless or guilty, suicidal thoughts. Interestingly enough, people with bipolar disorder actually complete suicide more than people with depression do. Probably something to do with that up and down nature of this. Um, but I think we can all relate to depression. I think people have felt depression and are familiar with it, but it has a range of severity, both in terms of how severe the depression gets and then how often and how long it lasts. So there are several different depressive disorders. DMDD, the first one here, disruptive mood dysregulation disorder, is something that was fairly controversial when it first came out because it seemed to imply that temper tantrums that children had might fit this diagnosis. And so that kind of gave rise to being able to medicate that. Now, this is one of the controversies we have with the DSM is about, medicating maybe normal, typical life events or medicating things that are caused by something else. So instead of addressing the problem, we're medicating the symptom. Major depression, you can see the different facets of that. That's probably the most common one. You can see premenstrual dysmorphic disorder. This one's gotten a little flack too. On one hand, I have known women who have said that they need to be on antidepressants in accordance with their cycle or treatment for PMS. But what happens if we ascribe women's depression to their cycle without having any evidence to back that up? That can be problematic as well. So that's another one of those issues that have to be worked out as part of diagnosis. Anxiety disorder, we have different types of anxieties here, either having to do with maintaining a high anxiety level for a longer period of time, or things like panic, where you have a flood of anxiety all at once, or panic that is caused by specific things, say a phobia, fear of open spaces, fear of heights, fear of an animal, something along those lines. So it's the presence of this disabling amount of anxiety. Again, I think we've all felt anxiety. It's just a matter of how does it become disabling? Does it hang around? And what triggers it? Now, a lot of things were part of anxiety disorders and now have been broken out into their own categories, considering obsessive compulsive disorder. So, what's called OCD, obsessive compulsive disorder, consists of two basic patterns. One is obsession. A person has a thought and they can't get that thought out of their head. And then there is a compulsion, a behavior that mostly alleviates that anxiety, but doesn't get rid of it. So that means it's going to come back again. So a person lives in this cycle of obsessiveness, ritual, obsessive thoughts, ritual, round and around. Um, So here are the different types of those obsessive compulsive disorders. You see body dysmorphic disorder here, where a person is preoccupied with something about their appearance, something about their body, an obsession that something's wrong with them and that they need to change it. Hoarding disorder was a type of OCD behavior, along with counting and checking. However, it's become its own category as time has gone on. Trichotillomania, that's a great word, compulsive hair pulling, excoriation disorder, which is very similar, but it comprises of people picking at their skin. Now, excoriation disorder is very interesting because there are a lot of people who pick at their skin, but it's a sign of drug withdrawal. So this is an important piece in terms of differential diagnosis. You can be watching somebody picking away at their skin, and you can say, well, there, I'm seeing it. I'm seeing the symptom of excoriation disorder, but it's caused by something else. It could be caused by cocaine withdrawals, for example. So again, medical, other, and unspecified. Now, trauma becomes an interesting thing, and it's something that is underdiagnosed in pretty much all of the settings I've worked in. It tends to be behind other things. It's a driver, but you don't always see it right away. You tend to see the psychosis or the mood swings, the depression, the anxiety, the addiction, but you tend not to see this stuff in the background. So, the whole idea of trauma is a person has experienced or witnessed a traumatic event where their physical or mental, emotional well being was threatened, and they continue to experience it beyond 30 days. So they have intense feelings. They have this hyper feeling of arousal all the time. They try to avoid situations that cause people to feel this way. You think about people avoiding fireworks on July 4th, and they may overreact to things. Their arousal system is dialed up all the time, so they're hyped up all the time, and then things can set that off from there. So there's a bunch of different diagnoses here. Reactive attachment, post-traumatic stress disorder is the one we probably gets the most press, and we'll talk about that the most. There's also adjustment disorders, and adjustment disorders we will discuss as well. Adjustment disorders kind of assume that you're going to be better in 6 months without treatment. Now, I know back in the day, we used to diagnose a lot of people with adjustment disorder, and that this is one of those that reimbursement is sort of threatened. Why does this person need help if they're going to be better in 6 months by themselves? So by underdiagnosing, sometimes we can set ourselves up. Another new one is prolonged grief disorder. We talked about bereavement before, which I'm guessing all of you have experienced. What happens when that grief hangs around longer than, say, 6 months? Is that pathological? Is that something that someone wants reimbursement for so that they can get help for it? Or are we pathologizing a normal human event? I'm sure you all grieved someone for longer than 6 months. So these are some of the controversies that come up out of this. On one hand, it's nice you have a diagnosis so you can put in for it, a person can get help. On the other side, we've now put a label on something that couldn't be more normal than grief, especially if that grief has complications to it, like COVID or other circumstances. So PTSD, here are the symptoms of that, lasts for a month. You have the memories, the nightmares. People talk about flashbacks, and I'm not such a fan of that term because in that moment, the person really is back in that situation. It's almost like a time travel thing, and they're acting appropriately to that time and situation. Dissociative disorders. And again, this was also in the anxiety family in the past. And it's where people experience such anxiety that they begin to almost disconnect from their environment. So fugue means flight. So this person just takes off and escapes because they can't stay where they are. Depersonalization, derealization disorder is where a person doesn't feel real or they feel like the world isn't real. They just sort of disconnect because of the extreme anxiety. Somatic symptom and related disorders. And our field was founded on the link between medical situations and psychiatric situations. If you go back, Freud studied glove paralysis, which was a medical phenomenon that was caused by the mind. It isn't a real medical problem as much as it is a psychiatric condition. And so here is that line between the physical and the mental. In the example of factitious disorder, you have people that are actually manufacturing physical symptoms. We had an example where a woman would come in and eat all of the chocolate out of our candy machine in the waiting area, and then get a chart made up in the ER and come back and she would have these sky high sugar levels and would get medically admitted. Sometimes there's a secondary gain out of being sick. There's something that this accomplishes. You may have heard of Munchausen's or Munchausen's by proxy, where a person makes themselves sick or makes someone else sick for attention or for some other sort of gain. Feeding and eating disorders, and this is a specialty I don't have, and I don't want to go too deeply into it, but I'm sure you've heard of anorexia nervosa, where people maintain an artificially low weight and engage in restricting or binging behaviors. Bulimia nervosa, where the binge eating and purging happens, but the person can maintain a normal weight. And then you just have binge eating disorder by itself. Interesting one about pica is we have a lot of that in the hospital, but very often people eat non-nutritious objects, which is the definition of that disorder, but they also do it for a secondary gain. They do it to get out of the hospital. They eat coins and they eat batteries and things like that. So you have to look again at some of these other factors that can be contributing. It's not just the presence of the symptom. Sleep wake disorders. This is another one I would want to have a doctor around. I don't want to diagnose this one myself. I do not want to diagnose sleep apnea or any of these things without looking at um, what the medical situation is. Another interesting one here is the circadian rhythm sleep wake disorders. A lot of medications are now being marketed to people who work evening shift and night shift and irregular shifts, like law enforcement does. And they are using the person's reaction. Again, they're treating it like it's a condition, but it's a natural event if you are sleeping against your body's normal cycle. So we're doing something deliberately unhealthy to ourselves, calling it a disorder, and then prescribing medication for it. So we could have a whole discussion about that. Sexual dysfunctions, again, here you need a doctor to help you out with this one. I would not want to do this one myself. And it has a lot to do with pain, problems with arousal, and all those sorts of things. And again, I'd be looking for other things that were going on here, but definitely in collaboration with a doctor. Gender dysphoria, this is another hot one. Do you feel like, you are the right gender? Do you feel like something about yourself needs to change? This is a specialty I do not have, and I would definitely recommend you get that specialty before working with people with this sort of issue. Disruptive impulse control and conduct disorders. Now, very often, some of these were reserved for childhood disorders, such as oppositional defiant disorder, where a child would be deliberately argumentative and oppositional. Conduct disorder would be when they did things that actually generated legal charges. The way I heard these two differentiated from each other was oppositional defiant is when they say it, conduct is when they do it. Intermittent explosive disorder, by the way, is more of an adult thing where there's just this pattern of tension building that then gets released with an explosive outburst, which the person immediately feels sorry for, but then the tension begins to build again. We also have antisocial personality disorder here, which we'll talk about more a little later. And then these other behaviors like fire setting, pyromania, or compulsive stealing, kleptomania, and things like that. Substance related and addictive disorders. Now, this might be where I actually have my biggest problem with how the DSM has handled this. Those of you who've been in this game a little bit remember when we had substance abuse and substance dependence. Abuse was overuse, and dependence is when you cross that line into tolerance and withdrawal, and it started to get much more severe. Now, my first issue is the treating it as a substance disorder. It's substance related and addictive disorders. It's all addiction, whether it's gambling or alcohol or a street drug or a prescription drug or computer games. Addiction is addiction is addiction. I don't think we do ourselves any favors by putting the focus on substances and then treating these process addictions, which I have a video about if you want to see that, as something second class or non-existent. So they have it as mild, moderate, and severe. Tolerance, which is needing more and more of the same substance to get the same result. And withdrawal, which is a physical and psychological reaction to not having the drug on board, are criteria. And then they have, you see the criteria for remission down here. So here's a partial list of the substances, and of course, new ones are being made all the time. So the DSM breaks them all in these different categories. So you almost have to assess a person for each one to see where they're at and what's present and what's past. I think that needlessly complicates the issue because most people are polyaddicted. They have multiple addictions. They use multiple things that tend to get them to the same effect. Or they kick one addiction, cross addict over to another. So that's one problem. Uh, I think it's only interesting as you look at the progression of someone's illness over time. What did they start with, as opposed to what did they get into? There's also a lot of misinformation out now about gateway drugs. Back in the generation I was from, we started with cigarettes and alcohol, moved into marijuana, and then moved on from there. Subsequent generations, it doesn't work that way. Gateway drugs are more about access than a drug itself. I've worked with children who have become exposed to OxyContin before they ever got exposed to alcohol or marijuana. So there's a bit of a breakdown in that. I also don't want to demonize the substance. The problem is not with the substance or the process. It's with the person themselves. It's with the addict, as it's called in the 12-step parlance. And again, this book kind of treats the process addictions as a second-class citizen here. Only gambling is considered as a process addiction. And despite the fact that these other processes fit every criteria that substance does, they're under review. So gaming addiction, sex addiction, there are inpatient facilities for these things right now. And it's been shown, particularly if you're a fan of Patrick Carnes, as I am, that these other processes fit the exact same criteria. And dividing everybody, okay, wait a minute, this is an alcoholic, this is a cocaine addict, this is not helpful. So moving on to neurocognitive disorders, this is another one that you want to have a doctor on board for. I do not want to be making diagnoses about what's going on neurologically in the brain based on report and observation alone. So you have all these different medical conditions, all of which can lead to cognitive impairment. Again, the injuries in the brain. Now, personality disorders. This one's a bit of a different breed than anything we've talked about so far. Personality disorders are something that develops very young in a person, and it impacts how they think, how they feel, how they act, and their relationships with other people. Personality disorders are also different in that they're what they call egosyntonic, which means the person's okay with it. People don't like feeling depressed. They don't like having mood swings. They don't like hearing voices. Personality disorders, the person likes who they are. I don't have a problem with who I am. So this is an outline of how the personality disorders are laid out. There are several of them. The cluster A's tend to be somewhat more psychotic appearing in presentation. Cluster B, we'll talk about a few of these a little more, are more dramatic in nature, and cluster C tends to be a little more quiet and withdrawn. Just another example of some bad names in our field. Obsessive compulsive personality disorder has nothing in common with obsessive compulsive disorder. but they do share a name. So, two we want to point out in particular, and these are the two we see most often. This first one is borderline personality disorder. Again, another horrible name. It stands for borderline psychotic, but I didn't know that until I was in the field a long time. How people with borderline personality disorder are identified, they are predominantly, but not exclusively, female. And we could have a good argument over whether that's overdiagnosed in women and underdiagnosed in men. That's a discussion I would love to have. Um, what really makes them stand out is self-injurious behavior, self-mutilating. They cut themselves, they burn themselves, they write the names of former partners in their skin. They manifest emotional pain into physical pain. They don't feel when they cut themselves. They go until they feel. And unfortunately, that can take longer and longer to do and put that person in more and more jeopardy. Another thing about borderline personality disorder is this pattern of unstable relationships. Every person with borderline personality disorder I've ever worked with has a significant trauma history, and they are basically spending their life trying to fill this hole within themselves. And they fill it with money, with drugs, with people. And they have this series of intense relationships where everybody comes in as a savior, but then it doesn't work out. And then the person betrays them. And by betraying them, I mean has a boundary. We've had people explode because their favorite staff person wasn't on for a day because it was their day off. There are these increasingly unrealistic demands that are made. And then when they're not met, person feels like they're being abandoned and they explode. So again, chronic feelings of emptiness, that sort of hole inside. And when I say that people with borderline personality disorder have trauma histories, I don't mean minor trauma histories. I mean prolonged, severe trauma histories. So antisocial personality. Now, this one is primarily male and also named very poorly. Most people think antisocial means, oh, they don't like people. This has more to do with the person doesn't have a conscience. What they want for themselves is all they want, and no one else's feelings or rights matters at all. They lie, they con, even when they don't get anything out of it. No regard for other people's safety or rights. Lots of legal problems. They tend to be dead or incarcerated by the age of 40 because it's hard to live like this. Very hard to live like this. There's a lot of controversy about whether, again, the predominantly male people who have antisocial personality disorder were they born without that part of their brain that says, "Oh, I really shouldn't do that," or that other person has feelings too, or did it was it beaten out of them or was it abused out of them? You can make that case. When I worked in corrections, the most of the people I saw that had antisocial personality disorder had a lot of old scars, had a lot of childhood scars and marks on them. So I really wonder where this came from. And again, you see a lot of this in corrections. You see a lot of this in inpatient settings. That's where these people end up. However, there are also a group of people that are antisocial that are actually very successful because part of being a successful person with antisocial personality disorder is being convincing, being seen as trustworthy, need to rein you in. So when we think about predators, whether it's child predators or people who prey on adults, there's a lot of this here. I always made the joke that, of the people that have antisocial personality disorder who are not incarcerated, many of them are in sales and many of them are in politics. And I'm going to stop there before I get myself in trouble. Moving on. The paraphilias. Now, this one's interesting as well because there are probably a lot of people in the world who engage in a lot of these activities, excepting pedophilia, um, that engage in these sexual behaviors. And when they're done between consenting adults, who cares? However, pedophilia, obvious exception here, but then also when this is involuntary or when it starts to cause a real problem in a person's functioning or they're really uncomfortable with it. Again, this kind of fits a sex addiction mode to a certain degree, where a person doesn't want to engage in these behaviors, but they feel like they need to, or they don't feel any sort of sexual gratification unless some of these behaviors are involved. Gets really complicated, and I'm going to refer you back to Patrick Carnes for that. He knows a lot more about that than I do. Now, some of the other categories in here that don't get enough press, I feel, are one is medication-induced movement disorders and other adverse effects of medication. Neuroleptic malignant syndrome can be lethal. Parkinsonism is relatively common around people that are taking the antipsychotics, especially the older antipsychotics. Dystonia, abnormal movements, and akathisia, the feeling like you're coming out of your skin. These are things we need to check in on because they can sound like other things. They can sound like anxiety. but they may have to do with medication. And then, of course, not everybody that we see needs a diagnosis. There may be something else completely going on. There may be something medical going on. There might be something going on in their life. So maybe something unspecified, or they may not have a diagnosis at all. We find a diagnosis anywhere we try to see one, but we shouldn't be looking for them everywhere. And under that heading of there may be other things going on. So some of the other categories that are seen here are suicidal behavior, self-injurious behavior, and here's where child maltreatment and neglect comes in. And again, this isn't going to be something that someone gives you at first interview. You're not worthy of that yet. We don't have that rapport yet, and your name and your title and all that are not going to get you that. Also, adult maltreatment and neglect. How much of a driver in these things is what's going on? And then we don't help that person by pathologizing them when they are the recipient of abuse or neglect. Other conditions that may be a focus of clinical attention, what's going on with their relationships, what's going on with their family, what's going on with school, what are these other dimensions of life that impact how a person functions? Because to me, that's what we're really talking about at the end of the day. How is that person functioning? I'm much more interested in that than I am what diagnosis they have. So now let's move into SMI and SPMI. So in the older days, there was a lot of talk about serious mental illness, and certain diagnoses were considered serious mental illness and some weren't. And I was always confused about that because if something wasn't a serious mental illness, then what was it? A whimsical mental illness, a silly mental illness, an unserious mental illness? I've never liked the term. And I have an article about this if you're more curious of following this up. We also interchange the words serious and severe, and I don't think that helps us as a field to have interchangeable terms. It either means something or it doesn't. We should try to be as scientific and consistent as possible. I admit, even though it's longer, I prefer the term severe and persistent mental illness because it captures those illnesses that, when they are there, are full on, almost like a seizure. It's there, it isn't. But then also the persistent nature of mental illness where it lasts over a long period of time. It may not be as severe, but it's there over a long period of time. And again, I'm much more concerned about how functional someone is and how to improve that functioning as opposed to what their diagnosis is. I think sometimes people become so preoccupied with the diagnosis that we forget what we're really about is helping people make better to get better. I think a lot of the job of diagnosis is over when you have lined that person up and when that person is in the proper treatment, with the exception of the educational function, which we'll talk about. So, person first language. We talked about the stigma that goes with certain diagnoses. When we call somebody a borderline or an antisocial, or even worse, the terms psychopath, sociopath, these words at that point they become used as a prognosis, which is this person isn't going to get better because they're or they're almost used as an insult. People are diagnosed more out of gut than by any sort of clinical rationale. The term chronic, it really means that a person's been ill, depending on the definition you use, for 1 or 2 years. It makes no reference about that person's prognosis of their future. But the term chronic is routinely used as synonymous with they're not going to get better. Also, not a fan of referring people by their illness. Oh, this person is a schizophrenic. They're a person with schizophrenia. Don't know if you want to be referred to by your medical problems. Oh, he's a hypertensive. You don't want somebody to be like that. You want them to be they were a person before the illness. They're going to be a person after the illness. And as part of person first language, trauma aware language, we're less concerned with what's wrong with you instead of what happened to you. Coming at the perspective that that person is trying to cope. They're trying to find the healthiest way to cope with what happened to them, as opposed to there's something wrong with them. Now, a lot of this comes from the field that I work in at Rutgers. Our discipline is called psychiatric rehabilitation. And my simple definition for psychiatric rehabilitation is it's abnormal psychology squared. It's the psychology of people that have their illness has been such that they have gotten out of the normal flow of life, of work and school and relationships. And now it's much more about psychiatric treatment and hospitals and medications and things like that. And the idea is much like rehabilitation after a accident to get your skills back so that you can function. That's kind of what this is. This thing has happened. So now how do we get you back to that point to teach you the skills and to treat this so that you can re-enter life and do whatever it was you were doing before or pick a new course in life? And there's also a huge piece where diagnosis not only helps indicate treatment, but it's a collaborative process with the person and also with the family. And then you also use it as an educational tool. They have to know what that is. One of my first jobs was working doing groups where we actually talked about what each diagnosis actually meant. People have been diagnosed with schizophrenia, they didn't know what it was. So the dangers of over and under diagnosis, first of all, you don't want to give somebody a diagnosis over and above what they have to make it sound more serious than it already is. For example, when we would see people with first breaks in the emergency room, people would say, "Oh my God, is it schizophrenia?" And they use the word schizophrenia like some people use the word cancer. They speak of it in hushed terms. I don't want to say it. I don't want to bring it in the room. Um, as we mentioned before, mental health diagnoses possess a huge stigma. And you're diagnosing young people. In the case of schizophrenia, you're probably diagnosing people between 18 and 22 who don't feel like there's anything wrong with them in any capacity. And of course, don't want to hear that there's anything wrong with them. And of course, there shouldn't be anything wrong with them. But yeah. Again, the cultural and societal elements of this, having a diagnosis changes a person's life. Having this illness changes a person's life. And people are very understandably sensitive to stigma and very sensitive to labels. Um, Other dangers of over and under diagnosis we talked about. You want to get paid. If you give certain diagnoses, even if it's an accurate diagnosis, you're not going to get paid. Now you got a moral dilemma on your hands. And of course, you're pressured to have a diagnosis because if you don't have a diagnosis, no one's going to pay you. So there's that part of it where we do the battle over reimbursement. Educational purposes we talked about. I love the idea of diagnosis as a teaching process. Open up the book. Let the person read the book. Be the translator of the book and of diagnosis to them. Let them make some of the decisions about what fits for them and what doesn't, instead of it's something that we do out of a book after the client's gone. I have seen also a lot of really neat apps and things about it too that people can access themselves. There's a lot more information out there than there used to be. Diagnosis fatigue. If you went to see a doctor because you'd hurt your ankle, and the doctor told you first that you'd broken the ankle, then told you later that you'd sprained it, and then told you later that you'd strained it, you would lose faith in that doctor very quickly. Lots of people in our field have been diagnosed with lots of different illnesses. And as a result, they kind of abandon the whole concept. They just say, well, none of you know what you're talking about. And to a degree, they're right. Diagnosis is a process. We don't always get it right off the bat. And even the book changes sometimes. So we also want to enlist a person in it because if they don't accept a diagnosis, they may also be struggling with the idea that they have a mental illness in the first place and then have any need for treatment whatsoever. I'm much more about the person being involved in treatment and then trying to fine tune what the diagnosis is than trying to win the war over diagnosis. And also the role of hope. The idea that no matter what someone's diagnosis is, that doesn't mean we know how this is going to turn out. Okay, you got this diagnosis, which is seen as being very severe. Doesn't mean you're not going to live a good life. And if you get a diagnosis that doesn't seem to be that severe, it doesn't mean that you're going to recover completely. Uh, the role of hope and the role of what can you do? What is it that you do that can help make these symptoms worse? And what is it you can do to help make these symptoms and this illness better is of primary concern. So PTSD, as we get into PTSD, um, everywhere I've worked, PTSD has been underdiagnosed. Some of the research I've seen indicates that significant numbers of people have PTSD. I see lower numbers in inpatient settings than I do, um, in the general population. I've seen rates of 60 to 80% among females with addictions. And we miss PTSD a lot, as I mentioned, because it's masked by addiction or it's covered up by these other symptoms. And again, people aren't necessarily going to share a trauma history with you right off the bat. This is the important part of diagnosis being a process. As they know you better, as you learn over time, as a person becomes triggered, they may not even be aware of it and they become triggered by something, and that's where you learn. So I would ask you to look for your own sake, look at the rates of PTSD, and then look where you work. Is it being diagnosed? Are you going there? And I think one of the reasons we don't go there is a lot of people, including we clinician types, have our own unresolved trauma. And you can't go there if you haven't tended to your own. So nobody wants to be reminded of their own trauma. So we don't address it with the client. It's a nice silent deal, except it doesn't help them get any better. So just to look at PTSD a little better, and before we do this, just the idea that there's a continuum. So people experience a traumatic stressor. They don't have a traumatic response to it. They're resilient. They respond from it. Then there are all these points on the curve before you get all the way over to PTSD. It's just not a yes, no sort of thing. I'll give you an example. In the one facility where I work, the staff will not they will not sit with their back to a door in a restaurant, no matter where they are, if they're on vacation or anything like that. And many of them, because one of the places I work is a forensic hospital, many of those staff have been injured or struck by patients. So is this behavior the result? Is this PTSD? And is this PTSD that got picked up at work? Well, I find out that many of the staff in the neighborhoods where they're from, you don't sit with your back to a door anywhere. They had that before they came to work. Was that a traumatic incident from their childhood? Is that cultural? Is that something that just, these are the questions we need to ask. So it's not that easy, but we have to ask those questions. I asked some of the staff, if you retired and moved to another state, would you sit with your back to the door? And they would say, no, I wouldn't do that. So it's very interesting. So the components of PTSD, having the exposure to the trauma, either directly or indirectly, the presence of these intrusive symptoms where it keeps coming back, the avoidance of stimuli that would remind you of it. Think of the people that don't like fireworks on the 4th of July. Negative mood, increased arousal. Part of the negative alteration in mood is a feeling of like fatalism, that they're not going to live forever, and powerlessness and things like that. And then a marked impairment in functioning. So that's PTSD. I would recommend that you assess everybody for PTSD. We call it universal precautions for trauma. We assume that everyone is traumatized, much like you put on rubber gloves for everybody in a doctor's office. We assume that everybody has some sort of trauma going on. It's just a matter of how much and how long. And not everybody goes, it's not 100% of the time, but I'd put it around 80 or 90, particularly depending on the setting where you work. Now, the relationship between trauma, mental illness, and addiction, this is a version that I've seen and I advocate for. Very often you see the addiction as the surface layer of what's going on. This is the outermost layer of the onion. And the battle now is to arrest the active phase of the addiction so that you can see what's going on underneath. And of course, as soon as that person stops, the symptoms of mental illness come raging out. If they're medicating depression, if they're medicating anxiety, if they're medicating mood swings or voices, they're going to come out. Then we need to address that, because that's always going to lead to a relapse. A person's going to go back to medicating it unless we come up with a better idea. And then in turn, underneath that mental illness, the core issue is the trauma. The trauma causes the psychiatric symptoms, which in turn need to be medicated, so the person medicates. So as we talked about, a collaborative process, open the book to the client, open the book, be the translator of the DSM. You can't just tell people to buy the book and read it. It's brutal. And I'm not telling you to buy the book and read it unless you work in the field. It is brutal. It's one of the reasons people keep watching these videos. So how do you communicate this diagnosis to the client and also their family? And how can we use this as an educational tool going forward? What can you do as far as homework assignments and outside learning so this person can educate themselves so that all involved can help? All involved are affected by the illness, and they can all be part of the solution as well. So just to wrap up, a couple pointers to take away. Diagnosis isn't a one-shot deal. It's an ongoing process. Don't be perfect. Perfect is the enemy of good. Consult the client and the family throughout the process, particularly about diagnosis. Diagnosis to me is less important than treatment. Its primary importance is pointing you in the right direction for treatment. Then it becomes important as an educational tool. How can you make this conversational? How can you take the jargon out of it so someone can hear you and understand you and be conversant in it and know about it? Even if a person doesn't agree with the diagnosis, knowledge is power. The more they know about it, the better off they are. Be ready for more changes. There's going to be another book, another manual, and things are going to change. Once you know the rules, they get changed. Consider the role of trauma as potentially universal. Consider the idea that almost everyone you're working with has a trauma background, and that trauma background has not been properly explored by them or by you. There's also a gentleman by the name of J. Eric Gentry, Forward Facing Trauma Therapy, really great book that helps address that. You're also never done learning. There's a place in diagnosis where I almost feel like I know less than I did 35 years ago. I've learned a lot, but there's so much more to know. And the fact that you're watching this and you've stayed with this long means that you're not done learning, and that's a good thing. Your clients will benefit from it, and you will as well. Here are the references that this material came from, including the article that I wrote about the serious and severe mental illness. This is our website. This is where all of our information is, and videos about um, mental illness, addiction, trauma, psychiatric hospitals, all sorts of things, all sorts of educational resources there as well. And the vast majority of them are free. So I thank you for viewing. I thank you for staying with me through this whole thing. And I wish you all the best, and I'll see you next time.